will be presenting alongside my good friend Felix Su, who's the Director of Policy here at MX, and I'm the Chief Information Officer. We're both involved in the Data Exchange Framework subcommittees in some form or the other. So let's get right into it. Some housekeeping, all lines will be muted. No matter how loud you scream, we won't be able to hear you, but you can submit a question through the Q&A. There's a box located at the bottom of the center of your screen. We'll go over those at the end of the agenda, and the session will be recorded as you heard. So if you have to leave early or if you want to share it with some others, it will be available in several different forms that are listed here below. So we thought we would start a little bit about a history of MX and sort of the size and scope of what we are. And I always like to start with our mission, which is to provide every healthcare organization in California with the information they need to improve care, enhance health, and lower costs, which is the triple aim. And I like that we're focused here in California. You can see our footprint here on the map on the right, which shows which percentage of the population we have by county that's listed there. Really, that translates into we have claims clinical lab data for 36 million Californians, which is the largest non-for-profit health information organization in California, and not actually just California, but in the United States. We have data for a large number of health plans, hospitals, and a variety of providers. One key stat we do like to talk about is ADT notifications. This is actually a requirement in the data exchange framework. MX has been doing this for years. Every month, we're delivering over 1.5 million notifications to folks who need to know if their patient showed up at the emergency department or was admitted to the hospital. And so that service is very widely used throughout our participants. Given that we have such a large and sensitive set of data, security is top of mind for us. And so we are HITRUST certified. We have been for 4 years. We're in the R2 certification, which is currently looks like a requirement for the QHIO program as well. We also have NCQA validated data, which helps health plans avoid some audits during their HENIS season. Probably the thing that we're the proudest of is this interoperability with 70+ EHRs. The reality is that there are a lot of EHRs in the market with small providers that are tough to connect to, and MX has done a significant amount of work to be able to connect to even the smallest of EHR vendors. And then lastly, beyond just California, we're connected to national networks that allow us to exchange data across the country. So that is the eHealth Exchange, that extends to Care Quality Network and Commonwealth Network. Okay, we can go to the next slide. We're going to talk a little bit about the framework in general, the data sharing agreement. The bulk of the content today will be agenda item number 2. Felix is going to talk about the grants program under the DSA Signatory side. And then we'll talk a little bit about if you want to partner with MX to meet those data sharing requirements, and then hopefully have some time for QA. There's a lot of information that we've tried to distill down into just a short amount of slides. So, if you have questions afterwards, please put them in the Q&A and we'll go over those. AB 133 is state law. It is past state law, not pending state law, that requires the establishment of this data exchange framework under CalHHS. And so what the data exchange framework has said is that there are required entities that must sign the data sharing agreement with the state by January 31st, 2023. That was about 5 months ago. And they're required to share health information by January 31st, 2024, about 7 or so months from now. And so the type of organizations that have to meet those requirements on those timelines are listed here below. They're essentially what you would think of as traditional organizations that maintain healthcare data. Hospitals, labs, plans, medical groups, SNFs, et cetera. So that timeline is coming very, very soon. To make it easy to get this DSA signed, CalHHS created this self-service portal. It's a pretty easy portal. You can go in there, you electronically sign the DSA. It's the same DSA that every other organization signs. It's not a document that gets negotiation. The state has published it, and that is the data sharing agreement. In addition to the DSA, the Data Exchange Framework has created this QHIO program, which stands for Qualified Health Information Organization. The concept behind this program is to essentially provide a one-stop shop for folks who want to comply with the Data Exchange Framework data sharing requirements. And they want to classify an institution as a QHIO that says, you can go there and they will meet all of the required data exchange requirements. They will meet all of the security requirements. They will submit themselves to audits and so forth. And so this program, you don't have to use a QHIO, but it's a good way for you to have a safe bet to say, I know that I can meet my requirements by connecting with these organizations. The application to become a QHIO was released for public comment. Public comment period closes here in 5 days. And so at that point, the state will take that back, finalize the application, and folks can then apply to become a QHIO. And they're expected to announce who those QHIOs are in July this year. Big bold font here, we fully intend to become a QHIO. We will apply. We have, in anticipation of this program, been ensuring that we can meet all of the required data exchange technical requirements and security requirements in advance. So we are definitely moving towards becoming a QHIO. That is to be determined by the application process, obviously. Okay, so if you're a provider, a hospital, and other healthcare organization, not a health plan, you have to meet the data sharing requirements. And here's how MX can help you. We will securely exchange the required clinical data. We'll collect that data from you. We'll use the nationally adopted technical standards that are defined from the Data Exchange Framework, and we will share that with other DSA signatories for required and permitted uses only. And that essentially aligns to what AB 133 says you're required to do. So this can be done through Manifest MedEx. And if we go to the next slide, for health plans, it's a little different. Health plans have to share adjudicated claims, encounter information from capitated providers, and then clinical data as defined by the standard here, which includes lab results if it's maintained by the payer. Again, same concept. This data has to be shared with other DSA signatories for the required and permitted purposes only. And Manifest MedEx is set up to be able to meet those requirements of a health plan. Okay, we're going to get into the fun part of it, and that is the grants program. And Felix Su is going to walk us through all the opportunities that the state is creating right now to help fund this program.
Thanks very much, Jason. Now, the main topic of today's webinar is obviously the state grants to support the DSA compliance needs that Jason just went over. And we want to spend as much time as possible on the ins and outs of this grant program. But what you need to know from the setup of this slide is that these grants are provided through the California state budget, and the authority for their funding, which is a little less than 50 million in all, is meant to last for up to 2 years. So we're talking about a time-limited finite resource, which is why there's going to be a competitive application process for the organizations that need to acquire the tools and technology to share data under the DSA. Next slide, please. Now, because these funds are available for only 2 years, and the date that many healthcare organizations have to begin sharing data for the DSA is January 31st of 2024, the state wants to move as quickly as possible to get these funds out the door to the organizations that can really use them. So to that end, there will be 3 rounds of funding through the end of this year. Round 1 opens as soon as May 15th, so maybe less than a week from today, and will run for approximately a month. Round 2 will open right afterwards and will also accept applications for about a month. Now, these first 2 rounds are purposefully sped up because they are targeted, and in fact, they're reserved for those entities that Jason showed on previously who have to sign the DSA and comply by this coming January. Hospitals, larger physician organizations and medical groups, health plans, labs, and skilled nursing facilities. If you are not in one of these mandatory categories, and as always, please review the list within your organization to make that determination, then you are not yet eligible to apply during these first 2 rounds of grant funding. But don't worry, there will be a 3rd round right afterward that will be open to the voluntary DSA signatories, such as county health departments and social service organizations and CBOs. The state agency, CDII, is going to provide a longer window, a little less than 3 months, for those applications in round 3 to be submitted. And they will be reserving enough funding during the first 2 rounds to make sure that there is at least a decent portion of the 47 million left over for the voluntary signatories to apply for. Now, CDII hasn't confirmed that they'll open additional rounds of funding after the first 3, but it all depends on the level of interest during those rounds. And no matter what, they'll announce no later than 30 days before the final grant application period closes. Next slide, please. So now let's talk about the grants themselves. They come in 2 categories or flavors that are summarized at a high level here, but let's dive right into the specifics. Next slide, please. So the first type of grant is the QHIO Onboarding Grant, which CDII sometimes refers to as the quote unquote assisted pathway. This is because your organization, if you choose to apply for this option, is specifically committing to use any funds you are awarded to help cover the cost of connecting to a qualified HOUSE. Again, like Jason said, one of these intermediaries that the state will officially designate as having proven themselves to be able to help support signatories to meet their data sharing requirements, and which we at MX will very much be positioning ourselves to earn that designation. Not only will the QHIO assist in the sense of providing the tools and the infrastructure for you to share data to comply, but the QHIO for the grant will also be responsible for managing the deliverables and the progress reports and submitting them to the state as required to receive the funding. And in many ways, really taking a lot of the administrative paperwork out of the grantee's hands. Jason will pick up the presentation at the end to talk a little bit about the types of activities and costs that would apply to choosing to onboard with MX as your QHIO grant partner. But first, let's address something up front in terms of an awkward timing issue. If you'll recall Jason explaining, the QHIOs probably won't be selected and announced until late June or early July. But rounds 1 and 2 of the funding open in mid-May and mid-June. So if that's the case, how will an organization know which QHIO to pick if they're interested in applying for this type of grant? The answer is that you won't know, and you are either going to leave the QHIO selection field blank in the application, or, and this is what we would strongly encourage, you can put down Manifest MedEx as your intended QHIO partner so we can work with you right away to begin helping you prepare the materials for your application, including the activities and the costs to include in the request for funding, and how we will document that you're successfully sharing data with us. And the good news is that for those of you who have already signed a participation agreement with MX, but haven't actually begun the onboarding process, as long as that contract was signed no earlier than January 1st of this year, you are still fully eligible to apply for the QHIO onboarding funding with MX as your intended partner. Next slide, please. Now, as an alternative to the QHIO onboarding grant, the state has provided a second grant option that's officially called the Technical Assistance Grants, or TA grants. Informally, they're often referred to as the quote, build your own solution or DIY pathway, which I personally feel is a bit of a misnomer because you will still very likely be engaging the help and services of a technology vendor or a data network to help you comply with the DSA and which costs you're seeking to cover through this grant option. Now, the TA grants are more open-ended than the QHIO onboarding grants and what they can fund. I won't go through all of these possibilities listed here. For the purposes of this webinar, what you should know is that if you choose to apply for a TA grant, you can still propose in your application to use that grant to help pay for things like implementing a tech solution or onboarding onto a data network to comply. And very importantly, that vendor or that solution could be a HIO or even a QHIO, just like the QHIO onboarding pathway. And if you propose a TA grant that is almost word for word identical to what you would pursue if you went through the QHIO onboarding route, that will still be completely acceptable and reviewed by the grant administrator. A couple of important caveats when considering both pathways. First is that you can only apply for one type of grant. And the second is that the grants can only be used in either pathway for initial onboarding and implementation, not ongoing costs, such as annual subscription fees. Remember, these are one-time opportunities. Next slide, please. So here's a pair of flowcharts that compares the two grant pathways from an application and an award process perspective. So under the TA grant, you, the applicant, directly receive the funds to help subsidize the costs of the resources that you request in your application, whether it's a vendor, an HIO, an EHR upgrade, or staff or personnel or consultants to help you comply with sharing your data under the DSA. With the QHIO onboarding grant, the funds directly go to the QHIO to offset things like the onboarding and implementation fees that they otherwise might normally be charging your organization to connect. There is an organization called the California Association of Health Information Exchanges, or CalHHS for short. You can see them on the diagram on the left, and they've been contracted by the state to specifically help administer the QHIO onboarding grant application. What's important to remember is that any DSA signatory who's interested in applying for a QHIO onboarding grant must work through CalHHS, who is technically required to help you complete and submit the application on your behalf. You'll need to request a one-on-one consultation with CalHHS to begin the process, and you can do so by emailing them at the email address that we'll provide at the end. Now, you're probably asking, why might you pick one type of grant over the other? Right now, what we at MX would say is that both paths look viable, giving your organization a great opportunity to help cover the costs of onboarding with us so you can begin to share data and comply with the DSA. Now, if you're bothered by the uncertainty that the QHIOs won't be announced until after the grant funding rounds open, that could be one reason for you to consider going the TA route and still name MX as your intended technology solution. If you instead go through the QHIO onboarding grant and you put MX down as your prospective QHIO, you can't really go wrong from that point either. Even in, at least what we think, very unlikely events that MX does not get chosen to become a QHIO, your QHIO onboarding grant can immediately convert to a TA grant to receive the same consideration and funding amount. Next slide, please. So either pathway you're looking at, to be eligible for these resources, you actually have to demonstrate a need for support beyond your current ability to comply with the DSA, which, as Jason pointed out, compliance is first and foremost about putting the clinical records and other health information that you hold as an organization out there in a way that can be shared and that is accessible by other DSA signatories who request it in the formats and the standards required by CDII. Now, there's probably some questions about what this means in practice, since in reality, a lot of you are probably at various points on the spectrum, ranging from not being able to share any health records electronically whatsoever, to being able to share some data that you have in some ways with some partners, to actually being able to meet all the data exchange requirements today under the DSA, in which case you would not be eligible for the funding grants. We are hoping that CDII does provide some more clarity on what this condition actually means. But the takeaway is that if you are not yet connected with MX today, and you feel that we could be able to help you meet some data sharing needs that you're currently lacking, then err on the side of reaching out to work with us on a potential grant application. You've got nothing to lose. Now let's turn to the issue of submitting a single group application for these grants, which in many cases may make a lot of sense compared to just each individual organization applying in a one-off manner. Now, many of you in the audience may be part of a larger health system, like a hospital with a medical foundation, or let's say a chain of skilled nursing facilities under the same ownership and operation. Or maybe you're a physician office or an FQHC that's part of an IPA or sharing administrative services with other practices through an MSO. These are all situations where a so-called umbrella applicant, maybe that hospital or IPA or MSO or parent company, can and perhaps should submit one single omnibus grant on behalf of all those subsidiaries or affiliates under that umbrella. In many ways, this parallels how signing the DSA worked in practice. Oftentimes, a parent organization was encouraged to execute the agreement on behalf of all of its subordinates, and CDII would like applicants the same approach here to the grants. Now, all this is probably a little complicated to follow, but I promise we will go through some visual examples that should make things a lot clearer to understand. Next slide, please. So here's the breakdown of what you're all probably most immediately interested in, which is how much funding is up for grabs. It is the same whether you're looking at a TA grant or a QHIO Onboarding Grant. All of the amounts here are listed in the CDII guidance document and other materials. But what we'd like you to focus on and even try to memorize are two of the amounts here: 50,000 for hospitals and 35,000 for physician organizations and medical groups. I'm asking you to hold those numbers in your head because we're going to use these amounts in a couple of examples that follow. As you do so, I also really want to focus on these two concepts that CDII has created to define what I'm going to call the units of this grant program. That is, how many distinct allocations CDII will recognize per application in terms of determining the total funding award. So the first definition is a so-called instance of an EHR or other type of electronic record system. Now, some of you with a health IT background are probably familiar with this terminology, but for the rest of us, including myself, it's helpful to think of an instance as being basically the group of healthcare organizations who can access the same set of electronic health records that they jointly create and maintain. I think the easiest example to use is a hospital and its affiliated medical group sharing the same EHR configuration. Let's say an instance of Epic. And all the providers at both the hospitals and the foundation are able to log into that Epic instance and access the same set of patient records. If you think about it, this makes sense from a conceptual standpoint. Presumably, that single EHR instance only needs a single data feed to be connected to an HIO or a potential QHIO like MX to allow real-time data sharing to flow simultaneously for both the hospital and the medical group. Now, CDII, in that case, obviously wouldn't be interested in funding the same connectivity for both the hospital and the medical group twice over, which is why they've chosen to only recognize and fund each individual instance and not necessarily each signatory in an application. Now, directly related to the concept of an instance is what they call a primary signatory. Now, oftentimes, the easiest way to think of that is who is the so-called largest player in that EHR instance. For a health system, you're probably looking at the main flagship hospital. If that hospital and say, again, a medical group are both part of the same system, and more importantly, are both using the same instance of the EHR, it's the hospital that has a greater patient volume and therefore will be the basis of determining the maximum funding award for that instance versus the medical group. So to sum up, the instance defines each individual unit of connectivity that will be funded in the DXF grant, while the primary signatory defines how much funding that particular unit is eligible for. Application can and often will include multiple instances, which means funding amounts are added across all of those instances to arrive at the total requests within an application. Clear as daylight, clear as mud. Don't worry, if the words don't do it for you, let's try some diagrams instead. So here's a scenario where an umbrella applicant, again, probably a single parent health system with several subordinates who has separately signed the DSA, has submitted a total application with a funding maximum of 100,000. Here, it looks like we have two separate medical groups and a hospital who make up the health system, and they've individually signed the DSA. So that's 3 signatories in the umbrella application. Does that mean 3 separate funding allocations to add up to get to the total request? The answer is no. And that's because we have 2 EHR instances that are represented in this funding request, even though there are 3 signatories. That's because 2 of the signatories share one of these instances. And in this example, it's the hospital and medical group 2, who are both using EHR instance 2 and can share and access records for the same set of patients. So for that instance, it's the hospital that sees more patients. So it gets defined as the primary signatory for their single instance. And sure enough, notice that the max funding amount for instance 2 is 50,000, which is pegged at the hospital as the primary signatory. Whereas if it had been based on the medical group, it would have only been 35,000. Now let's take a look at instance 1. That instance only serves medical group 1. So that component of this application, this umbrella application, should only be funded up to 35,000, right? No? Oh, sorry, trick question. Instead, it says 50,000. And notice how there's an asterisk next to the medical group 1 that says, quote unquote, meets underserved community and no CalHOP criteria. Oh, great. What does that mean? So it turns out that CDII, with the goal of addressing and advancing equity in data sharing as part of the grant program, will raise the max funding amount per instance if the primary signatory meets 2 criteria. 1, that they serve Californians in marginalized populations, which is measured by your patient or revenue mix of Medi-Cal, dual eligibles, and uninsured patients being at least 30%. And or you are located in an underserved geographic area, which is defined as being in the bottom quartile of what's known as the Healthy Places Index. The second criteria that has to be satisfied is that the primary signatory has not previously received HIO onboarding funds from a past state funding program known as CalHOP, which ran from 2020 to 2021, and which some of you may be familiar with or have even participated in. So, that medical group from the last example must have met both of these criteria and was thus eligible for 50,000, not just the baseline 35,000 per instance. Now, aside from increasing the potential funding amount, these criteria are also important because they affect how your application is scored and prioritized by CDII. Signatories who serve underserved communities or have not received funding from past programs will stand a better chance of being chosen for a grant award in any given funding cycle. Now, the guidance document from the state goes into detail about how your organization will demonstrate that it meets these criteria through steps like attestation and reporting. So you definitely want to read that carefully. You want to take some time and care in demonstrating this in your grant submission if it applies to you. It's no accident that many of the signatories who lack the ability to share data in real time today are oftentimes the same ones who are serving in the safety net in underserved areas and populations. It literally can pay to be deliberate in documenting this carefully in your application, as it can raise both the score and your chances of winning a grant, as well as the amount of resources you can potentially qualify for if you're selected. Okay, so let's look at one more example here. Now we have two signatories, a medical group and a lab, yet three instances, which can certainly happen. Here, the medical group that signed the DSA has providers who use two different instances. Hypothetically, maybe their central location is on Cerner, while their downtown clinics use an instance of NextGen. So even though it's one signatory, a medical group in this case, it would take two separate interfaces or connections to the two separate instances to enable all the clinical records that are stored and maintained within the group to be shared for full DSA compliance. Therefore, that signatory, this medical group, is eligible for funding for two, not just one instance, each at the baseline amount of $35,000, since they aren't listed as serving an underserved area or population. So making you do all this mental math and go through these hypotheticals wasn't just to make you dizzy or frustrated during your lunch hour for the sake of it. The takeaway is really that we at MX don't want to just be your chosen QHIO or tech solution in your grant application. We want to really be at your elbow to help you maximize your application's chances for success by working through all of these various factors and variables that can influence the decision. And now, as you can see here, if you choose to apply for a QHIO or onboarding grant or TA grant, you really can't just make up a number. And you, in many cases, probably can't just reach for whatever maximum amount is listed that you think applies to your organization. CDII really is going to require you to show your work in the form of a budget request that outlines what activities will be supported by the grant and their estimated costs. And the more persuasive and the more rigorous you are with that budget and the rest of the application, the better positioned you will be to be awarded a grant, or at least have your application deferred for automatic reconsideration in the next round. Let me give you an example. Remember how I said it was worth thinking about when it makes sense to submit as an umbrella, let's say through your IPA or MSO, versus a bunch of individual applications, practice by practice? Well, let's say you're an IPA with 10 separate EHR instances, and they're all considered to be underserved communities that haven't received CalHOP funding previously. So you are allowed to apply for 10 times 50,000. And if you did so, your total package submission would hit the funding cap of 500,000 that CDI is allowing. But if you submit something that comes in under that total budget request, let's say you ask for 20% less, so 400,000 or 40K per instance, CDII is going to potentially rate your application higher than it otherwise would. Again, that shouldn't surprise us if we think about how the state is responsible for being judicious and maximizing the reach and impact of a one-time limited pot of funds. It's this type of strategic consideration and partnership that we at the MX team, with all of our experience from working with many of our participants to get funded through past programs like CalHOP, are really here to help you think through. And this is the last slide for me. There are a couple of key differences about how the QHIO grant and the TA grant work in terms of how grantees will demonstrate their progress to access their funding. In both cases, you'll be paid across two milestones. The first being that you sign a contract with your chosen QHIO, and the second being that you have actually furnish the proof that is required to demonstrate that you're actually sharing data as required by the DSA. And Jason will talk more about that at the end, about what that proof entails if you work with us through Manifest MedEx. Now, for the QHIO Onboarding Grant, technically, if your organization submits during 2023, you can apply to have the funding dispersed by demonstrating your progress anytime before the close of the year. If you submit afterwards, you have 12 months till after the award to complete milestone 1 and 24 months to complete milestone 2. So starting in 2024, CDII will only accept and review these milestone progress reports each quarter and will pay out the funds based on the successful milestones 30 days after the submission. So that estimated schedule is what the chart on the right side here represents. The bottom line here is that if you are a mandatory DSA signatory that needs a QHIO or technology solution to help you comply with data sharing, you really want to act quickly and try to get your application submitted in the first 2 rounds. And you want to work with a partner who can help you reach both milestones of contracting and exchanging data as quickly as possible so the resources can flow to you as soon as this year. And on that second piece, as Jason will close us out with, we really think there's a good case for looking to us at Manifest MedEx as your ideal partner. Jason, back to you.
Great. Thank you so much, Felix. I know that that can seem rather complicated, and I would say hats off to CDII for developing a grant program that is pretty flexible and covers a very wide range of scenarios and organization types, and focusing on some extra dollars for those in the underserved community. So again, we'll make these slides available afterwards so folks can review afterwards to help clarify any questions that they may have from that. Great examples. So let's talk about partnering with MX. If you wanted to partner with MX to meet those requirements, what do you need to do? We've kind of boiled a lot of information down into 3 key steps. The first one is to complete the necessary paperwork. So sign the DSA. Probably sound like a broken record, but you can't do anything really until that DSA is signed. It was due to be signed back in January. There's nothing stopping folks from going and signing now. You can still continue to sign that DSA on the CalHHS website. So that is step number 1. The next step would be to sign a participation agreement with MX. That is the document that allows us to exchange data with you. It has our business associate agreement. It says that we will make sure your data is shared appropriately and only for permitted uses. And so once that's signed, then you could submit your grant application with the state as Felix described. And as you can see, there are a variety of paths for that. Once the paperwork is done, then the work of integrating your data streams with MX can begin. And essentially, that means getting your data to MX, the data that's required by the DSA, and we will ensure that that data gets shared out with the other DSA signatories in all of the required transaction patterns that the state has listed. That process of integrating your data stream is generally starts with a kickoff call and technical readiness. This is where we assess how ready your EHR is to begin exchanging this data. That helps us inform of any gaps that we may need to fill, or engagement we need to do with your EHR vendor. And then we establish the connectivity. And then we go through the testing, which you all are a part of, to make sure that the data is flowing through across, and then you can go live. Depending upon a wide variety of scenarios, in rare cases, this can actually happen in just a couple of weeks. Typically, it's more like 6 to 8 weeks for that process to occur. The factors, if you want to think about, I want to be on the 2-week end rather than the 8-week end, the factors there are your EHR vendors availability. So when you reach out to an EHR, as many of you know, they may not be ready to turn on a dime. And so the earlier you reach out to them and let them know you want to start going down this path, the better. And then the second other factor is your ability to engage with MX. So again, we require your organization to help us with testing and the validation of things. And so if we get all those stars aligned of you all are ready and have resources assigned and your EHR vendor as well, we can go very, very quickly with these implementations. Now, you've just met with steps 1 and 2, DSA, DXF data sharing requirements. We'll take that and we'll make it available. In addition to that, step number 3 here is there's a whole series of benefits that you get from joining Manifest MedEx. Longitudinal health record, ADT notifications, and more. So back on that first slide, when I talked about all of the different types of organizations sending data to MX and the number of patients we have data on, we take all of that information, line it up, match the patient, combine all that into a single longitudinal record for an individual. You can log into our system and view that longitudinal portal. So very easy access. We have a great CS team that gets you spun up on how to use that and trained on how to use that very, very quickly. It's access at your fingertips. The second is ADT notifications. And that is for folks that want to monitor a certain set of patients to know if they've been admitted to the ED or a hospital inpatient. We can notify you very quickly. We have a tool that you can log into and see that, as well as we have the capability to deliver that to you in a spreadsheet or other electronic forms. There are many, many more services that MX offers, and those come along with signing our participation agreement. So it's a little bit more of a benefit than just complying with the DXF by joining and going through Manifest MedEx. So next slide. Okay, next steps. Sign the DSA. Again, step number 1 is to sign that DSA. And then review that the grants application guidance document and templates to determine, do you think you're eligible for a grant? You absolutely can contact Manifest MedEx to discuss your options, your proposed activities, your funding. We'll help you determine your budget, your type, your application, to navigate that complicated path that Felix described of umbrella versus individual and what kind of funding should you put. And then you can apply. Again, you can apply for either the TA grant or the QHIO Onboarding Grant. Either of those are acceptable methods. It tells you here, if you do go with the QHIO Onboarding Grant, you will need to contact CalHHS to begin that application process with them. And please remember, if you're going to go that route, to list Manifest MedEx as your intended QHIO, if that's what you request. Then you submit your grant application during an open round on the grant portal. There is limited funding, so the sooner the better. And then as things evolve, as they are with the DXF program, and we are keeping up to date our social media. And also we have a DXF resource page on our website that's linked here that talks about the future webinars, the policies, links to all the official documentation, upcoming events, and more. So if you want to be in the know, it's a great place for you to stay in touch with. Okay. Next slide. So to preview the next little event here, we have another webinar coming up, and we'll have Adam Harrison, our Chief Growth Officer, Brittany Wepler, our Chief of Staff, and Felix Su, who gets to do all DSA and DXF related webinars as he is our resident expert. So we have another webinar on the 25th of May from 12 to noon. There's a link, there should be a link in the chat so that you can just register today and you can not have to worry about searching for that in your inbox to attend that meeting. Okay, I think that might be our last slide before questions and answers. Great. So while I've been chatting, Felix, have we gotten some questions that we want to run through?
We sure have. And the first note I'd be happy to take, Jason, and I can lob the next one to you, is a really good one. Can organizations use excess grant funding for educational activities that support the implementation and compliance with DXF? Now, I specifically wanted to take that question because it allows me to backtrack to a issue in the last part of my overview that I wanted to get across in a clearer way because it's important. One of the key differences between how the TA grants and the QHIO grants work in terms of demonstrating progress is that, again, the QHIO grant is the assisted pathway. So the QHIO will be providing the evidence, supporting documents to demonstrate that you signed the contract and that for milestone 2, you are sharing data in real time. And with the TA grants, because it is quote unquote, build your own solution or DIY, you, the grantee, will formally have to report on your own deliverables and milestones. But obviously we at MX can still help you with that on the back end if you choose us as your technology solution partner. Now, with that out of the way, with the actual question, technically CDI really wants to see the resources that they approve to be fully spent on what you actually propose in the grant application. And to support that, if you choose the TA grant route, milestone 1 actually requires you to provide an invoice or other type of evidence to show that you have spent at least 50% of the grant budget requested on procuring resources to meet your defined outcome. Those resources, again, could be the technology, the contract with the vendor, the EHR interface upgrade, or hiring and staffing personnel needed to enable eventually to get to compliance. Now, because the question was about education and outreach, I do want to mention that the TA grant can be used to fund staff training and workflows that is necessary for your organization to comply with data sharing. But again, the purpose of the grants is really to be spent on activities that are directly related to sharing data in real time as required by the DSA. Jason, do you want to pull another question that we're seeing coming through here?
So most of them are grant questions. So I'm going to take one that is good for me. And so we had a question about, can we speak to how MX helps meet the individual access requirements under the data exchange framework and data sharing agreement? Great question. So individual access means an actual individual requesting their data as a patient or a person, not necessarily coming through an organization. And so that means, Jason Buckner, if I wanted to be able to access all of this information that's been dictated by the data exchange framework, I should be able to have a mechanism to go and say, I want all of my data pulled into me. And so, as you can imagine, probably the most challenging aspect of that topic is what we will call in the IT world, the identity proofing of the individual. And so there is a national standard, I can't quite remember the acronym now, that at least some of the information blocking regulations may point to, or TEFCA may point to, that states here is the level of identity proofing that is the sort of the gold standard, if you will. And these include things like taking a picture of your ID, using an app on a phone to scan your face and make sure that it's you, to really make sure that it is an individual and not a bot, and not someone who may have found an ID on the street, and so forth. And so we are evaluating partners right now to determine which ones will help perform that identity proofing on behalf of MX. We fully intend to support individual access at MX. It is required if you're going to be a QHIO to be able to support all transaction patterns, and individual access is a transaction that's dictated. So we are going down that road. We fully expect to support individual access. Great question. Felix,
Okay.
I think there's some other grant questions for you.
Yeah. Some of these, wow, I guess some folks couldn't get enough with the examples about instances and signatories, because we have one here. Can an umbrella applicant be a primary signatory? Technically, yes. For example, going back to that hypothetical, if a hospital or health system originally was the signatory on behalf of itself and some of the affiliated subordinate organizations let's say a medical group, a lab, a skilled nursing facility that are all under that parent organization. If that hospital or health system submits a grant application for itself and all of those subsidiaries, then the hospital is considered an umbrella applicant. And if that hospital and the medical group, like it often is in so many cases, share the same EHR instance to look at patient records for the same set of individuals, then that hospital, again, by virtue of being the largest entity in terms of the size of the patient panel or patients being served, would be the primary signatory that would define the funding maximum for that instance. Here's a easy but important one to clarify. If my organization does not qualify for the first round of grant applications, can we apply again? Most certainly, yes. And also, in some cases, an application that meets a minimum score threshold from CDII and the grant administrator, it may not qualify to get awarded in that round, but it automatically gets deferred to the next round for reconsideration. So in that case, you wouldn't have to reapply, although you certainly could if you felt like you could strengthen your submission.
Right. Okay. I do not see any more questions. So I think with that, we can actually wrap up a little early. I will remind folks that the next webinar is in the chat. So, and these slides will be available and they were recorded. So they'll be there for you to reference them. We appreciate you all making time out of your busy days during lunch. Yeah, have a great afternoon.